So the ARMANI trial is a phase 3 trial conducted in the first-line setting of the advanced HER2-negative disease. The ARMANI trial enrolled the patients with advanced HER2-negative gastric cancer who had disease control after an induction phase of 3 months of FOLFOX or CAPOX within the clinical practice, and then were randomized on one-to-one basis to Paclitaxel plus ramucirumab, that was the experimental arm, or the control arm, which was the continuation of oxaliplatin-based chemotherapy for additional 3 months, followed by fluoropyrimidine maintenance. The primary endpoint of this trial was progression-free survival. Overall survival was also a key secondary endpoint. And at the ESMO GI 2024, we also presented data regarding PD-L1 CPS claudin 18.2 and mismatch repair, and their correlation with outcomes. Okay, the ARMANI trial enrolled 280 patients across 31 Italian centers, and the median follow-up of the trial was 43.7 months. As I previously said, the primary endpoint was progression-free survival, and progression-free survival was significantly improved by the switch maintenance strategy with Paclitaxel plus ramucirumab. In fact, the median progression-free survival was 6.6 versus 3.5 months, and this corresponded to an hazard ratio of 0.64 in favor of the experimental arm. Importantly, also the overall survival was significantly improved by the switch maintenance. In fact, the median overall survival was 12.6 versus 10.4 months. And this corresponded to a ratio of 0.75 in favor of Paclitaxel plus ramucirumab. In this ESMO presentation, we also assessed the impact of the experimental treatment across the key clinical and molecular subgroups. Specifically, the experimental arm with Paclitaxel plus ramucirumab significantly improved both PFS and OS across all the key relevant clinical subgroups. Moreover, at the ESMO 2024, we presented data regarding key biomarkers, including PD-L1 CPS, claudin 18.2, and mismatch repair, because the assessment of these biomarkers is very important to in the patient decision-making in the first-line setting of the advanced HER2-negative disease. And we found that about 41% in the biomarker-evaluable population had PD-L1 CPS of 5 or more, 39% of patients had claudin 18.2 positivity, and 5% of patients had mismatch repair deficiency as expected in this patient population. And we found no significant interaction between PD-L1 status and the treatment arm, and similar results were also observed for the claudin 18.2 status and the treatment arm. As you know, advanced HER2-negative gastric cancer is a very hard to treat disease, and less than 50% of patients are eligible to second-line therapy due to worsening of the performance status following disease progression from the chemotherapy regimens. And the ARMANI strategy demonstrated that a switch maintenance or an early second-line strategy could improve the patient outcomes irrespective of the main clinical characteristics. Moreover, we also demonstrated that about 1 out of 3 patients enrolled in the ARMANI trial had a so-called triple-negative tumor. A triple-negative tumor corresponding to low or absent PD-L1 expression, claudin 18.2 negativity, or mismatch repair proficiency. This subset of patients is not eligible to PD-1 or claudin 18.2 inhibitors. So the ARMANI strategy could represent a promising treatment for patients who are not eligible for targeted therapies.